Good afternoon, everyone, and thank you for joining us in the third of our series of webinars from Ophthalmic Consultants London. Thank you, everyone who has joined us for our previous two, and welcome to everyone who's joining us today for the first time. Before we start, there are just a few points. For those who have been asking about previous webinars, they are all recorded, as this one will be too, and they're available to watch on our YouTube channel, Ophthalmic Consultants of London. So if you do want to catch up on the previous ones or view this one later, it will be on our YouTube channel. And the second point, we've had a few emails asking about whether optometrists can come in to see our clinic at Ophthalmic Consultants of London in terms of if you'd like to refer patients. And yes, that is possible. So once London is a safer place, we'd love to welcome you to our clinic and show you around the diagnostics and our theatre and meet the consultants who are there. So please get in touch with myself or Veronica, our clinic manager, and that can be arranged. So for today's lecture, there is one CET point available for this webinar, and it's for optometrists, dispensing opticians, therapeutic optometrists, and contact lens opticians. As previous, the lecture will run for about 45 minutes with questions at the end. So for those joining us for the first time, there is a Q&A box at the bottom. So if you have any questions throughout the webinar, please just type them and we'll get through as many as we can at the end of the lecture. So let me introduce you to today's speaker. It's Susan Sarangapani. Susan is a consultant ophthalmic surgeon who works with us at Ophthalmic Consultants of London. She is a clinical director of ophthalmology and a consultant ophthalmic surgeon at the Luton and Dunstable Hospital Trust. She's an expert specialist in oculoplastics, orbital and lacrimal surgery. So Susan, thank you very much. I shall pass it over to you and you can share the screen when you're ready.
Lovely. So good afternoon, everybody. Thank you for joining myself and the other OCL team members for our webinar this afternoon, which is on dry eyes. So I'm just going to share my screen now. So some of you may have already heard me giving a talk on dry eye at the OCL clinic at the beginning of March. This talk has been updated, so I do hope that you find the lecture interesting and get some learning points from it. So the title of the talk today is Does Dry Eye Matter? And I'm sure, like me, your clinics are full of patients who have dry eyes. And if you were to ask them, any of those patients, does dry eye matter? Does it affect your life? I'm sure that you would get a resounding yes as a response. Globally, it's very interesting that approximately 25 to 50% of the population have dry eyes, so diagnosed or undiagnosed. So this is a significant group of people. Yet dry eyes can be really difficult to diagnose and treat. It can be challenging because there's multifactorial causes, and commonly there can be a lack of correlation between the signs and symptoms of dry eye disease. But once you've made the diagnosis of dry eye disease in a patient, a key factor that I've found is that early treatment of these patients makes a huge difference in improving the symptoms and their quality of life. So the Dry Eye Disease Workshop, or DEWS, is an international committee of doctors and researchers who came together in order to set out definitions and a classification system for dry eye disease. And they published their first report in 2007 and updated the report 10 years later in 2017. So one of the learning objectives of this talk is to look at the 2017 updated DEWS 2 report and to also discuss what happens when dry eye disease patients are not treated properly. There are also lots of different diagnostic tools for identifying and classifying dry eye disease patients, so we'll be looking at this too. It can be difficult to understand why some patients have a difference between their signs and symptoms when they have dry eye disease. We've all got patients who complain a lot, and yet when we examine them, we don't actually find any major conjunctival or corneal damage. And conversely, there are patients who have a lot of corneal staining, damaged conjunctiva and soft tissue, and yet who don't complain very much at all. So we're going to be discussing today the key mechanisms involved in dry eye disease. And once this is understood, dry eye disease will become much more easier to diagnose and treat. One thing that I found is it's important to realise that the quality of life in dry eye disease patients is impaired. So in fact, we have numerous studies that have shown that patients who do have severe dry eye disease and also have a cardiac history, for example, who have severe angina, actually compare the effect that dry eye disease has on their life to being on a level with their cardiac symptoms. I don't know about you, but when I first heard this, I had no idea that these patients actually found their dry eye disease symptoms so debilitating and that it affected their life to such a degree. So what I've also found is that dry eye disease patients have instability in their vision. And by that, what I mean is they've got difficulty in carrying out their daily activities, so driving or using the computer and other daily tasks. Now, this is really interesting because you can check their vision, and whilst they can have a good visual acuity on Snellen or Logmar testing, they actually have a major impairment in their quality of vision, and we're going to be discussing this later. And these studies have actually shown that this degree of impairment can cause depression in patients because they're suffering with their daily tasks on a regular basis. So one major difficulty in diagnosing dry eyes is there are many different diseases that can cause dry eyes. So we can all clinically diagnose the patient who's got an unstable tear film by using fluorescein, or the one who's aqueous deficient by using a Schirmer's test. But there are many different diseases that have nothing in common, and yet they can all cause dry eyes. So for example, you've got patients with Sjogren's syndrome, patients who have menopause, other autoimmune diseases like rheumatoid arthritis, thyroid eye disease, those who've recently had ocular surgery, patients like glaucoma patients who have preservatives in their drops, and so on. So this means that there are lots of different diseases which can commonly manifest as dry eye. Also, it seems oversimplified to classify patients as either being aqueous deficient or as evaporative, because we know that only approximately 10% of dry eye disease patients are actually aqueous deficient, and the other 90% actually have a combination of evaporative disease, evaporative and aqueous deficiency, or have a mixed picture. Other things to also consider is the environment. Does a patient read a lot, use a computer a lot? We've already talked about different types of drugs that can contribute to dry eye disease, but also the external environment, the humidity of that the patient is in, wind velocity, and their local environmental temperature, even inside their house. So putting all this together, a French ophthalmologist whose name is Baudouin, apologies to any French speakers out there for my pronunciation, put this all together and published a theory on dry eye disease, which he called the vicious cycle. So what does this vicious cycle mean? It means that when you have a tear film that's unstable, it actually results in a series of biological events. So you've got hyperosmotic stress, you've got apoptosis, which is cell death. That causes mechanical tissue damage, it causes nerve stimulation, and that all leads to inflammatory changes in the eye. We all know that chronic or long-term inflammation damages and destroys cells and tissues that are vital to the maintenance of the tear film, for example, the conjunctival goblet cells. The reason it's called a vicious cycle is this goes on and on. The loss of the goblet cells can lead to reduced mucus production, which leads to further inflammation, and so the cycle continues. We've also got meibomian gland dysfunction and blepharitis, which has its own role, and this can change the lipid levels in the tear film, which takes part in the vicious cycle, and this perpetuates the dry eye disease process. So when we have a patient with dry eye disease, we need to remember that these patients can actually enter this vicious cycle at any point, and it may even be a combination of events, for example, menopause plus blepharitis plus contact lens wear and using preservative eye drops that cause the dry eye disease, or it could be an autoimmune condition like arthritis, thyroid eye disease, or Sjogren's syndrome. So what we need to remember is no two dry eye disease patients are the same, and all the causes of the dry eye disease need to be addressed in order for the patient to be adequately treated. So going back to the JEWS 2 definition of dry eyes, one important change from the earlier definition is that there's loss of homeostasis or stability regulation of the tear film. And this is noted to be a common factor in all dry eye disease patients. And this leads to hyperosmolarity, ocular surface inflammation, and also neurosensory abnormalities. And we're going to be discussing that further in the lecture. So whilst the 2007 JEWS 1 report focused on the fact that it was multifactorial, it focused on the fact that it was just a disease of the tears and the ocular surface that resulted in the common dry eye disease symptoms of discomfort, visual disturbance, and damage to the ocular surface. But what was really important is that it highlighted that there's an increased osmolarity of the tear film and associated inflammation. And this, as we discussed, has been further defined in JEWS 2 by looking further at the loss of homeostasis of the tear film. So just a quick recap on the structure of the tear film. It's a very simplified picture, courtesy of Allergan. And traditionally, there's always been said to be 3 distinct layers of the tear film. You've got your lipid layer that prevents evaporation of the tears. You've got your aqueous or watery layer that contains the electrolytes and proteins, and that layer helps to nourish and protect the cornea. And you've also got your mucin layer, which coats the cornea and adheres the tears to the eye, and it helps the other layers to mix together and forms a tear film. So a tear film has, a stable tear film has multiple functions, and this diagram illustrates just how complex the makeup of tears are. So we've got electrolytes, sodium, potassium, chloride. We've also got different enzymes and proteins. We've got antibodies, we've got mucus products, and all of these actually protect and lubricate the eye and help reduce infection, washing away surface debris, keeping the surface clear and helping refraction and oxygen transfer from the air to the cornea. Going back to the JEWS 2 classification, once we lose this tear film homeostasis and the tear film becomes unstable, the actual component of the tears change. And this diagram illustrates how you get an increase in your electrolyte levels, your proteins go down, antibodies go up, and you get a lot of debris from the apoptosed or dead cells from the conjunctiva and the cornea. We've already discussed how difficult it can be to make a diagnosis of dry eye disease, especially in cases where patients are very symptomatic but have no corneal staining or other obvious clinical signs. So we know in dry eye disease patients that they have increased tear film osmolarity. So one method to aid dry eye disease diagnosis is to actually measure the tear film osmolarity. And this can be done by a tear lab machine, which is said to be the gold standard in the objective diagnosis of dry eye disease, and is, which, as we know, is a single best marker of disease severity. If there is a facility available to measure the tear film osmolarity, we define abnormal osmolarity as anything greater than 300 milliosmoles per litre, or a difference between the two eyes of greater than or equal to 8 milliosmoles per litre, and this indicates that the tear film is actually unstable. And when the measurement is abnormal, the tear film has lost its stability, and the patient has dry eyes. However, this test only tells you that the patient has dry eyes. It doesn't tell you why the patient has dry eyes. So it's still important to look for and treat all the causes of dry eye disease. And if you do get a patient who is symptomatic, who has a normal osmolarity when you measure it, it is important to actually also consider other conditions. For example, any changes in the conjunctiva, like conjunctival chalasis, whether the patient has any allergic eye disease, whether there's any basement membrane problems, and so on. So another way to assess dry eye disease is to test for ocular inflammation using a biomarker. A biomarker is a molecule that's found in bodily fluids, including the tears, and the level in which they are found in the bodily fluid is a sign of the active disease process which is going on, in the case of dry eye disease, of inflammation. Matrix metalloproteinase 9, or MMP9, is an important biomarker in chronic inflammation, and studies have shown that it's elevated in patients who have chronic dry eye disease. So essentially, this is actually a very easy test to use. It takes approximately 10 minutes to get a result. And you can see in the photograph that a sample of tears is being collected, and then in the rectangular part, a test card is inserted, and it's essentially like akin to doing a pregnancy test. You wait for 2 lines to come up, which indicates a positive test or high levels of MMP9. So one of the other ways that's really helped us in our understanding of the role that inflammation and pain play in dry eye disease is the use of confocal microscopy, which can identify inflammatory cells and also nerve damage. So if you look at the top row of the images, they're confocal microscopy pictures of the tarsal plate, and the bottom row are images of the cornea. And the first set of images, the first vertical set of images, where it says normal, indicate what normal tarsal plate and cornea look like under confocal microscopy. But in the second and third set of images, you can see abnormalities in the shape and the diameter of the corneal nerves, and also in the width of the corneal cells. So sometimes these damaged nerves come in direct contact with the inflammatory cells that you get in dry eye disease, and this is the reason why some dry eye disease patients have severe pain, which is far more than expected based on clinical examination. So additionally, in this subset of patients, it's important to check that they haven't used preservatives on eye drop, which will contribute to the corneal toxicity and increase any pain and irritation. So why is the cornea so sensitive? The reason for this is that it's one of the most densely innervated parts of the body in terms of sensory nerve fibres. You have your trigeminal nerve, which carries your sensory nerve fibres for your reflex tear production. And within the cornea, it's situated in 3 positions. So you have sensory nerves in the epithelium, below the epithelium, and also in the midstroma. So initial nerve damage in the cornea can be very painful, but when you've got dry eye disease patients where there's chronic nerve damage, that then can cause anaesthetic cornea. So let's look now at what happens when dry eye disease is not treated. Not treating dry eye disease patients is not really an option. We know that these patients are in a self-perpetuating cycle of inflammation where they've got ocular surface damage, they've got neurosensory damage, and that if these patients are left untreated, or if they're not treated as early as possible, then these patients will have a significant reduction in their quality of life. So here are a few examples of what happens if we don't treat dry eye disease patients. So this first set of pictures shows inflammatory changes. The first picture, you've got a picture of episcleritis. Second picture, we've got symblephron. And the third picture shows an inflamed tarsal plate with papillae and follicles. Going down to the second row of pictures, we've got a patient with the first and second pictures of the second row. You've got a patient with severe blepharitis and soft tissue inflammation. And in the third patient, we've got a picture of a resolving bacterial keratitis secondary to inflammation. So there's these next images, series of images, are more examples of ocular surface changes in dry eye disease. First picture is a contact lens wearer with dry eye disease who had bacterial keratitis. Second picture is a patient who's got an anaesthetic cornea and epithelial damage. And the last picture also is a patient with an anaesthetic cornea who's got epithelial damage secondary to dry eyes. What I found is that it's really important to appreciate that there is a difference between best corrected visual acuity as measured on a Snellen chart and a patient's functional visual acuity. So you may have a patient who is 6/6 or better, who seems to have a good visual acuity on conventional testing, yet they struggle with everyday activities that most of us take for granted, like reading or watching a computer. I found in my practice that no two dry eye disease patients will have the same symptoms, and no dry eye disease patient has ever actually said to me, I have dry eyes. So we all have the patient who says, my eyes feel tight, they're sensitive to light, my vision's blurred, stinging, or you may actually have a combination of all of these symptoms. So looking at classification of dry eye disease patients, historically, ocular surface staining was an important way of grading the severity of dry eye disease. Various different classification systems were published. This is the Oxford grading system, and this assesses the surface damage by evaluating the fluorescein staining on the cornea, the conjunctiva, and also the tarsal plate conjunctiva. Graded 0 to 5 based on severity. But we all know now, having based on the most recent research and publications, that this is not the best way to classify dry eye disease, because it's missing the subclinical inflammation but in the absence of the availability of osmolarity and biomarker testing, this type of classification is still used in some units. There have been lots of different types of quality of life diagnostic tools that have been used, and these tend to be in the form of questionnaires that are used to evaluate dry eye disease patients. So I appreciate in practice we're all very busy. We don't have time to give out questionnaires to all our dry eye disease patients. But just so that you're aware that these diagnostic tools are out there and are being used, they range from the visual analog scale, which is the smiley face scale, through to the SPEED questionnaire, which is quite a simple questionnaire, the standard patient evaluation of eye disease, which measures the symptoms, the frequency and severity of dry eye disease, all the way through to the ocular surface disease index, which is a 12 question questionnaire, and that measures the vision related quality of life at different times during the day. Moving on to the treatment of dry eye disease, being aware that it's a multifactorial condition and all the causes that contribute to dry eye disease means that it's really important to take a full history to ensure that all dry eye disease causes are being addressed. And I personally find that educating patients as to the chronic nature of the condition and that treatment is lifelong, we can't cure them, and the aim of any treatment is symptom control rather than curative, I find really helpful. And every time I see a dry eye disease patient, I actually reinforce this. We've already discussed the discrepancy between signs and symptoms in dry eye disease and the challenges of treating these patients. And also we will be talking further on in this webinar about the treatment algorithm which came out from the DEWS-2 study, which is very helpful in the diagnosis and treatment of patients with dry eye disease. We all have diagnostic challenges, and when I have a patient with dry eye disease, the four main conditions or the four main patients that I find are challenging are the asymptomatic patient, the patient who has chronic disabling pain, the patient who has a damaged ocular surface, who may be symptomatic or asymptomatic, and the challenges in how do you treat these patients, and also the patients who have no obvious corneal or conjunctival damage. So, as we've already said, it's really important to consider whether these patients have a subclinical ocular surface inflammation, do they have an anesthetic cornea, has there been trigeminal nerve damage, and whether they've got any preservatives which may be exacerbating their ocular surface toxicity. Previously, this was a challenge in patients who were taking glaucoma drops, but now as more and more preservative-free glaucoma treatments become available, this has actually been really helpful in treating patients with dry eye disease. So we've already spoken about the vicious cycle, but when considering what treatment to start in dry eye disease patients, it's really important to remember that different treatments will act at different points of the cycle. And usually dry eye disease patients require all the underlying factors to be treated in order to achieve stability. So, for example, it may seem common sense, but there's blepharitis, you treat the blepharitis. If there's inflammation, you can treat the patient with omega-3, perhaps autologous blood. But whatever the aim of the treatment is, what we're trying to do is to break this continuous cycle of damage that leads to inflammation, that goes around and leads to more damage, and a very symptomatic patient. So the treatment algorithm for dry eye disease that was published by DEWS-2 may seem oversimplistic, but it's actually a great place to start. So literally, as with any treatment algorithm, just follow it down. If you've got an asymptomatic patient who's got signs of ocular surface, if such a patient is about to go for cataract surgery or laser eye surgery, it may be prudent to give them some preventative treatment in the form of drops pre-surgery. I won't keep talking again about neurotrophic conditions because we've already talked a lot about the nerve damage. But you've also got patients who are symptomatic, they've got signs of disease. You may feel that you've treated all their underlying disease processes and you still can't manage to treat, or you can't still manage to get their symptoms under control. And if I reach a point with such patients, there's nothing wrong with referring them in for a second opinion, just to make sure that there's nothing that's been missed. Or quite often I will also write to the GP and ask for a full list of drugs, again, just to make sure that the patient isn't actually taking any medication which can be contributing to their dry eye disease. For patients who have no signs and who have chronic neuropathic pain, occasionally, and this is very rare, I have even referred a patient on for pain management. So what are the topical treatments that are available to us in order to treat dry eye disease? There's lots of different drops. I'm sure all of you are using preservative-free drops for your patients. We've got newer drops. We've got VisuXL, which contains a matrix of hyaluronic acid with coenzyme Q. So the idea behind this drop is that the hyaluronic acid matrix stabilizes the tear film, while the coenzyme Q helps to repair the ocular damage. In terms of drops, so in terms of gel and ointment, we've got Xylene, which is preservative-free, lanolin-free. Vitapos contains vitamin A, but also what I advocate in my dry eye disease patients is starting anti-inflammatory treatment early in order to break the cycle of dry eye disease. Now, this may involve giving them some preservative-free steroids, for example, Dexa-free, some topical non-steroidals, for example, Voltarol. We're going to talk a little bit further about using cyclosporine to modulate the immune response, and also in some patients using autologous serum. Other non-topical treatments which are available, punctal plugs can be helpful, as can actually making sure that the patient with blepharitis or meibomian gland disease is following their lid hygiene with their omega-3. And in some patients who have associated acne rosacea, is ensuring that they have a course of tetracycline antibiotics. So there's no doubt, whilst I used to think dry eye disease was just give the patient some topical lubricants, it's way more complex than that. It's an interaction of your tear film with your immune system, with your nervous system, and also environmental factors. The lack of correlation between signs and symptoms can be challenging, and the fact that aqueous and evaporative dry eye symptoms usually coexist. Patient education is really important, but the one key point, if you only take one key point from this lecture, is to take away that early diagnosis and stabling these dry eye disease patients can't be underestimated in preventing cell damage and getting this disease under control. So, where are we going in the future with dry eye disease? Like any disease process, there's always ongoing studies, there's always ongoing treatments. The DREAM trial, which was published in the New England Journal of Medicine in 2018, was a multi-center, double-blinded clinical trial in America of 535 patients. And there were two arms to the trial. 349 patients were randomized to the omega-3. So they had daily oral supplements of 3,000 milligrams of omega-3. And 186 patients were given the equivalent amount of olive oil. And the way that the way that the doctors measured the primary outcome or results is they measured the change in the baseline score on the ocular surface disease index that we talked about with the quality of life tool, which essentially measures the severity of symptoms, the degree of corneal and conjunctival staining, tear film breakup time, and also Schirmer's test. And what was really interesting is that whilst both the groups, so the group that were on the omega-3 and the group that were on the olive oil placebo, both had an improvement in their OSDI score, there was no statistically significant difference between the two groups. Now, there's been a lot of controversy about this trial, especially as the earlier omega-3 trials in the early 2000s showed that omega-3 was very helpful. So clearly further studies are required here, but it does raise the interesting prospect of nutritional supplements in planning and treating dry eye disease in the future. Another study is the Sansika study, which was again carried out in America, which looked at the efficacy and safety of cyclosporin eye drops on the signs and symptoms of patients with severe dry eye disease. So again, this was a multi-center, double-blind, randomized trial that took place over 6 months, and patients who were graded who had grade 4 on the modified Oxford scale, so the modified scale that we've previously talked about, were either treated with topical cyclosporin or with a vehicle or of topical that's used with a topical cyclosporin. So the by that what I mean is a molecule used for the cyclosporin to go into the tissue, but it doesn't have the cyclosporin component. And what this study assessed was the corneal damage from baseline measurements and also the corneal inflammation. And they concluded that cyclosporin is well tolerated and it's really effective in improving corneal damage and inflammation in patients who have severe keratitis. So more recently, IPL treatment, or intense pulse light therapy with meibomian gland disease, has been looked at as coming into being used as a treatment for dry eye disease. For those who are not aware, it's a widely accepted treatment for cosmetic dermatology and acne rosacea, and it's commonly used in the States and Canada in patients who have dry eye disease. The way that physicians use the IPL treatment in dry eye disease there is they confirm the patient actually does have dry eye disease and blepharitis using the SPEED questionnaires and the OSDI questionnaires before they actually start treating them with IPL. And IPL involves the patient attending for multiple treatment sessions, together with the patient also having expression of the meibomian gland secretions at the same time. The laser settings used are dependent on the Fitzpatrick skin type, but this is a really exciting way that we may be able to that we may be able to offer our severe dry eye disease patients. There's lots of studies published. I've just cited one of the studies on the slide, and this is a treatment that we're actually going to be bringing into OCL in Cavendish Street to be able to offer to our dry eye disease patients. So that was a whistle-stop tour of dry eye disease and treatment. Thank you all very much for watching, and I'll hand over to Purvi for the questions.
Susan, thank you so much. If you could stop sharing your screen when you're ready, that would be great. Thanks so much. That was a great lecture. I'm sure it's been interesting to a lot of us that have these problematic dry eye patients that come in. And on the basis of that, I do have a question that says, what is your treatment for somebody who comes in with dry eye where you have tried everything? Where do you go after that?
So I assume by everything you mean you've treated the blepharitis and given them a number of different preservative-free lubricating drops. The first thing I do is check compliance, because patients quite often, you may give them the drops or suggest the drops, they may not actually be complying. I make sure I've treated all the underlying conditions, that if, for example, any associated drugs, any autoimmune disease, I'm tried non-topical treatments like plugs. But if I reach the point where I really, this is a patient with severe keratitis and symptoms, I have a low threshold for starting the patient on cyclosporin, because I find that this is a really effective way of stabilizing these patients. And it may be that they have to have cyclosporin and a topical treatment, but it is a really effective treatment.
Thanks, Susan. On that line, someone's asked about the new eye drop Zidra, as whether you've used it as a topical.
Sorry, I didn't.
InflammaDry.
Okay, so I personally haven't used that drop, so I can't comment on how effective it is.
Okay, thank you. Another one here. What are the clinical differences seen on the slit lamp between evaporative and aqueous deficient dry eye?
So when we think of evaporative, when we put the fluorescein drop into the patient's eye, we may see an oily tear film. So that indicates there's increased lipid levels and lipid instability, which may be increasing the amount of the evaporative dry eye component. We already know that only 10% are aqueous, so probably the best way of differentiating between the two is to carry out a Schirmer's test to assess, which is use an assessment for aqueous dry eye, and using the results of that in combination with the slit lamp examination for an oily tear film.
Thank you. And as you just mentioned that, there was a question that asks, is there a place for the Schirmer's test in practice?
I find that that's not a test that's used so frequently, because given that only 10% of dry eye disease patients have solely aqueous deficiency, that's not something that I personally carry out regularly, because I know that the majority of my patients, and 90%, are actually going to be evaporative or have a mixed picture.
Okay, and someone's asked, Susan, thank you, how early would you start treatment for dry eye? For example, how do you justify treating an asymptomatic patient who you just happen to incidentally find that has moderate dry eye?
So that can be really difficult, because again, I've spoken about compliance. How do you ask a patient who doesn't have any symptoms to start using eye drops regularly? And the answer is, you can suggest it, but they may not. So the way I approach it is to suggest to the patient who may start having symptoms, for example, when they're using their computer screen a lot, to start using drops before they use their computer or before they're reading, to try and get them into the routine of using drops. It's a difficult one, because if you're giving a patient a treatment that's that they can't feel any immediate relief from, they may not comply with treatment. So in some patients, I've actually taken photographs and said, this is what a normal front surface, ocular surface of the eye should look like. This is what normal cornea should look like. And this is what yours looks like. And that's why I'm asking you to take this treatment. And so if you work with the patient in order to explain to them why you're starting the treatment, I find that really helps with compliance.
Thanks, Susan. Along that line, a lot of people are asking about the tear lab. I mean, obviously that osmolarity check is a nice bit of kit to have if you can afford it in practice. I know that, you know, the consumables are pretty expensive for that kit too. So how do you go about treating someone if your instruments show that actually they've got dry eyes, whereas they have no symptoms? Or likewise, vice versa, someone's showing a lot of symptoms and yet your test is showing that actually your osmolarity is absolutely fine?
Well, again, you know, that it's like anything. You have the two extremes and everything in between. And so I appreciate the tear lab does cost in the region of about £10,000, which is why it's not, you know, readily used everywhere. It is a very good treatment. It is a very good diagnostic tool. The test cards also required to be bought. But again, I find that, you know, you have to, it goes back to the diagnostic challenges. Does this patient have subclinical inflammation? Does this patient have subclinical, you know, corneal damage? You know, I think it's always good to question, you know, why is there a discrepancy between the signs and symptoms? And, you know, usually if you question it and think beyond it, you can actually identify which patients need to be treated, or you can actually you know, make a note that, you know, I need to watch this patient because they're at risk of developing more severe dry eye symptoms or signs, and, you know, make sure that they do get adequately treated. Thank
you, Susan. A couple of questions about MGD. I think it wasn't mentioned as much in your talks because we talked about other things. So people are asking about MGD in general, and also the lipid flow. I don't know whether you know clinics that use the lipid flow, what your thoughts are about that.
Okay, so I didn't touch too much on blepharitis because I didn't want to bore everybody out there with blepharitis, given the amount of blepharitis that there is actually out there. But I do feel that, you know, it is important to establish a patient on a really good meibomian gland disease treatment regime in order to, as well as treating their their dry eye disease with topical lubricants. And this can take some time, in terms of it can take a number of consultations. You know, what may work for one patient may not work for another. Some people will still swear by diluted baby shampoo and bicarbonate of soda. Everybody's different. Whereas the heat pads that can be used are also, may benefit other people. But I generally find that the more simple I can keep it, the more likely it is that the patient will use a treatment that's prescribed and actually use it regularly.
Thank you, Susan. How about the recommendation of omega-3 or flaxseed oil in the treatment, and does it interfere with any other medication?
So the early studies in the 2000 showed the benefit of omega-3 and flaxseed oil in treating meibomian gland dysfunction and blepharitis. But we've discussed about the DREAM study, which actually showed that it may be just as useful taking a spoon of olive oil every day, as it can for omega-3. As far as I'm aware, omega-3 doesn't have any contraindications with other medication. We have a lot of patients who have coexisting immune conditions and cardiac disease who still take omega-3 as well, and it's a good supplement to take. So I do advocate using omega-3, and for it does help stabilize the meibomian gland function.
Thank you. A couple of questions on autoimmune disease. One is, if you find there is inflammation in the eye and you suspect it may be autoimmune, do you refer patients? Do we refer patients if we do suspect there's something going on? Or for conditions like Sjögren's syndrome, are there blood tests to confirm it, or how do we know that's what they have?
So usually it's done by diagnostically on clinical symptoms, but if you suspect that a patient has an autoimmune disease, you should refer them, simply because if it's affecting their eyes, it's likely to be affecting other organs in the body. So it is really important that they are referred on to the hospital in order to assess whether they have any other organs being affected. So yes, please refer. Thank you.
Susan, how do you think we can focus on the prevention of dry eye rather than treating it?
Well, prevention is always better than cure, but I think that first of all you have to diagnose someone as having dry eye disease. I mean, given that up to 50% of patients globally have dry eye disease, that equally means the other 50% don't have dry eye disease. So some patients may never have symptomatic severe dry eye disease. So I feel the place to focus on is to catch the patients early, when they have early dry eye disease, and then focus on treating them then, before they get into the cycle of severe inflammation and soft tissue damage.
Perfect, thank you. How about the use of Lissamine green?
It's not something that I use so much. Again, I find in clinical practice that, yes, we haven't got access to confocal microscopy, but I feel that, if we can get inflammatory markers and if we can get the osmolarity tests done, they're more predictive and of relevance in dry eye disease treatment.
Thank you. How about a few questions on the holistic approach to dry eye? So I know we talk a little bit about omega-3, but any other natural remedies, or someone suggesting aloe vera? Is that a...
What do you mean, aloe vera topical drops, or did they not say?
A natural remedy, assuming aloe vera juice or...
Just, okay. It's not something that I personally have experience on, so I can't comment on using aloe vera juice. So that's not something I could comment on.
That's fine. Another good question, actually. Susan, medications, any particular ones that should be on our list to look out for that we know can cause dry eye?
So my lecture slides will be available on the via the OCL link. But if you look, I think it's on slide 3, there was a list of drugs to look out for, including beta blockers, some antidepressants, So there are a number of drugs that do contribute to dry eye disease. Also, vitamin A deficiency, which may not be easy to diagnose. Also, patients who are on diuretics or which can be treatment for hypertension. So all of those drugs all cause dry eye disease.
Thank you. We do actually have quite a few questions. I'm going to keep going with a few of them if that's okay.
That's fine, yes.
We've got a bit of time, so I'm going to go through them. Any thoughts on what drops you should try first? Do you have a preference of whether you start carbomer gels or ointments, something else? And also, how long do you keep one treatment going before you think it's not working, you need to add something or change it?
So I always start with a preservative-free drop, and it again depends on how symptomatic the patient is and clinically their degree of ocular surface damage. And also the degree of inflammation. So what I would tend to do is start on a preservative-free drop, maybe, for example, Hakkasan or maybe Visu XL, and also use something like Vitapos or Xalin ointment at night. I would then see the patient again after about 3 months. And if they come in and say that there has been absolutely no relief from their symptoms, then I will actually stop the medication and change it to something else. Because I find that if you give a patient too many drops to use, it can become confusing and then they may not actually use it. So I tend to use a combination of maybe a maximum of usually a maximum of 2 drops, and also an ointment or a gel in order to keep their symptoms under control.
Thank you. And you've talked about preservative-free drops, sorry. Somebody's asking, why is it always better to give preservative-free drops?
Because the preservative in the drops, for example, Bell's benzalkonium chloride, can increase the ocular toxicity. So it can cause tissue damage to the conjunctiva and cornea. So thinking about the vicious cycle of dry eyes, it just perpetuates, causing further inflammation and further tissue damage, which will just perpetuate the dry eye symptoms.
Thank you, Susan. There's 2 questions about the NHS and saying, what's the NHS doing about dry eye patients? I know there's a reduced service now, so is this affecting the quality of life for a lot of people?
Well, I mean, it must be. I mean, there are 2 components to when you're talking about the NHS treatment of dry eye disease patients. A lot of the CCGs will only allow the GPs to prescribe a certain number of dry eye disease drops, whereas if a patient buys the drops, sees someone privately and buys and gets a drop on prescription, or sees their optom and buys a drop from their optom, then they are by far getting access to much better drops. I mean, a lot of GPs are still prescribing hypermelos, and we discussed right at the beginning of the webinar that it's, with dry eye disease, we now know it's a lot more complex than just saying, oh, a patient has dry eyes, let's give them some lubricating drops. It's what type of lubricating drops are you actually giving this patient? And so, yes, there must be a lot of patients who are not being able to access their GPs and their, obviously their clinics at the moment. And for those patients, all we can tell them is just continue with their lubricating drops that they have got, or buy some over the counter from the chemist or their optician.
Thank you. And in terms of, you said lots of different drops, do you have suggestions for what you'd use for somebody with evaporative dry eye against aqueous deficient or mucin deficient? I mean, do you have different drops that you tend to give to these patients, and how do we know which ones we're meant to give?
It can be difficult, especially because we know 90% of them, of dry eye disease patients, have a mixed picture, so they don't neatly fit into aqueous deficiency or evaporative. So that's why, it can be a challenge to know what to give. So, for example, we've talked about preservative-free drops already. I don't differentiate between the 2. I know that, there are some drops, sustained drops and other drops that are supposed to be better for patients with meibomian gland dysfunction. clinically, I found that if I give those drops to a patient with meibomian gland dysfunction and dry eye, it doesn't significantly help them more than giving, you know, a drop that I would give to someone who had less of a problem with blepharitis. So I haven't found a correlation. I tend to focus on, you know, what am I trying to achieve with the treatment? I'm trying to reduce the inflammation, so maybe give them an anti-inflammatory. I'm trying to increase the lubrication, so lubricate the surface.
Thank you. In terms of optometrists referring patients on, let's say we have tried all the drops and maybe the patient isn't the most compliant, but we're giving it a good go. At what point, if they keep coming back to us, do we refer?
I think that depends. If your patient is coming back for maybe the second or third time, and you've tried 3 lines of treatment and it's not helping, and you can't get them established on a regular symptomatic you know, treatment system, then I feel that it would be better to refer the patient in. I mean, we have, you know, either myself or another colleague at OCL would be happy to see the patients. But I feel rather than, you know, once you've reached the maybe third or fourth time where you're still hitting a brick wall, you know, refer them in. We're very happy to give an opinion.
Thank you. A couple of other points we have, pregnant ladies and contact lens wearers. Do you recommend you cease contact lens wear in those suffering with dry eye? I mean, a lot of the times it's really hard to say to a contact lens patient, sorry, your eyes are dry, you have to stop, even if you've tried all the other types of contact lenses. And also any drops or anything you can't do on a pregnant lady, any diagnostic tools you can't use, or any drops? So
usually with the lubricating drops, there's, you know, because they don't have an active drug component, there's no contraindication to using them in patients who are pregnant who have dry eye disease. I appreciate that contact lens wearers with dry eye disease who don't want to wear glasses, that can be a struggle, but that, you know, ultimately there will come a point where, you know, if the ocular surface damage you know, is serious enough, then, you know, I'm quite blatant with my patients, and I will say to them, you are at risk of getting an ulcer in your eye with a really bad infection, and you're at risk that you can even go blind. You know, sometimes you just have to be blunt with a patient, and they may not like what you have to hear. They may not like to hear what you have to say. You know, sometimes what I do find, if I catch the patient early on, for example, if they're using daily contact lenses, I will say to the patient, and they've got mild to moderate dry eye disease, I will say to them, try using some lubricating preservative-free drops in your eyes before you put your contact lenses in, and then during the day, you know, if your eyes feel dry, you can put some drops in, because, you know, patients wearing daily disposables, it's not going to be a big deal if they're throwing them out at the end of the day, that you're concerned that the drops are actually going to damage the contact lens surface.
Thank you, Susan. A couple of points in hydration or dehydration. Is there any correlation between us and someone to drink a lot of water for dry eye? And likewise, as somebody who gets through a lot of caffeine, cups of tea and coffee, like we've probably all been doing these past days, yeah. Is there a link with dry eye with an increased intake of this?
No. So I don't advocate drinking lots of water to treat your dry eye disease. No, there's no direct correlation.
Thank you. And the drinking a lot of caffeine?
No, conversely, no.
Okay. I mean, there are a fair few more questions, but if there are any specific ones, what I'll do is I'll put them to Susan in an email, and as soon as she gets back to me, I will send the reply out, if that's okay. It's just that I'm aware that we are now approaching the hour. So Susan, thank you so much for joining us today. What I am going to do is launch a poll. Those who've been with us before know that there's just a very short poll that if you could all fill in, that would be fantastic. And I'm just wondering if it's launched. It has. Thank you. I think if you're watching on a phone, you may need to just click the launch poll button, and that will be it. So if anyone does have any further questions, you can email me at purvi@oclvision.com. Otherwise, the questions I have here, I will pose them to Susan at a later date. We do have 3 more webinars next week, the links of which will be sent out. So you will either find them on Facebook or Instagram, otherwise you will get an email later on today for the 3 future webinars next week, one of which is corneal grafts. There's a second lecture on glaucoma in this current COVID pandemic, and the third is the therapeutic applications of laser to treat corneal diseases and also in cataract surgery. So please look out for the registration details on that, and we look forward to seeing you then. So we're just going to wait for a few more responses. Thank you to everyone who's replying to the poll. I think we're nearly there. So Susan, I'm going to keep you on there just a little bit longer until everyone has completed the poll. And that's great, thank you. And as a final point, there were a few questions towards the end about referring to OCL. Yes, please do get in touch with us. So we do have a process in this situation of what we're doing regarding referrals and when we need to see them and the urgency. So if you have anybody that needs to be seen, please do get in touch with us, and we will advise you of what the process will be. So thank you very much. Right, I am going to end that poll. Thank you very much, everybody. Susan, thank you again so much. Have a great weekend. Enjoy the bank. It is a bank holiday tomorrow, isn't it? No, it's not.
No.
No. Enjoy the weekend, and we will see you soon. Thank you.
Great. Thank you all very much for watching the webinar. And if you would like any other talks on ocular plastics or lacrimal surgery or lacrimal disease, please do email us and I'm sure we can set something up. Thank you very much and have a great weekend.